Thank you very much, Mr. Chairperson. Ladies and gentlemen, it is my great pleasure to have an opportunity to present my data in the APHR's joint session. My disclosure information. Let me start from the history of AF computational modeling. In silico modeling of atrial fibrillation has been already developed in 1964 by Gordon Moore. Currently, various nice and sophisticated realistic simulation modelings have been introduced. After the introduction of a human AF modeling in 1964, AF computation modeling has been evolving and continuously applying more detailed electrophysiology, including restitution, calcium dynamics, or electrical remodelings. Currently, we are using Kurmanshi-Ramirez-Nettel model in our research. In spite of a long history of human AF modeling, the high burden of computational power has been a hurdle for its clinical application. However, we adopted the GPU system in 2013 and drastically reduced computational time, which is applicable to clinical medicine. Recently, we upgraded our AF computation modeling software, Cubia, to display APD restitution map, which reflect the passive wave break and persistent rotational reentry of phase singularities, in addition to dominant frequency sites. Moreover, we developed an auto-detection algorithm for atrial wall thickness to overcome the limitation of a monolayer modeling of a Cubia. Before developing the virtual AAD protocol, we tested the computational model guided AF catheter ablation. Professor Troyanov group developed the MRI late gadolinium enhancement based AF modeling to target the proper ablation of extra PV foci as a proof of concept study. And we also conducted randomized clinical trial with 118 patients with persistent AFib and modeling guided the linear ablation, improved the ablation outcome compared with empirical ablation. However, at the time, we used monolayer homogeneous Cubia prototype modeling. And this is Cubia AF2 randomized clinical trial protocol. Using an updated Cubia version integrated by patient-specific voltage conduction velocity and fiber orientation. At the beginning of the procedure, we apply the voltage map after restoring the sinus by a cardioversion. Then we integrate clinical mapping data to AF modeling, induce the virtual AF, and localize dominant frequency site. By improving the computational power, we can generate the DF map within 30 or 40 minutes during PBI procedure by operators. After circumferential PBI isolation, DF information is given to the operator for additional dominant frequency ablation. This is a synopsis of Cubia reflecting personalized atrial anatomy, histology, and electrophysiology. In patients with persistent AFib, we acquire the voltage activation map during atrial pacing. Then clinical team export and send the bipolar EGM data to core lab. In the core lab, we integrated the clinical map to AF modeling, reflecting fiber orientation and local fibrosis map. Then induce virtual atrial fibrillation to localize dominant frequency areas. It takes 30 to 40 minutes for computation, and the outcome data is sent to the operator within the PBI procedures. The enrolled patients were randomly assigned to either computational modeling guided ablation group and empirical ablation groups. And this is patient characteristic. Two groups were well balanced, and all enrolled patients had persistent AFib, and 62% of them were long-standing persistent AFib state, and the mean left atrial size was 45 millimeter, and mean procedure time was 167 minutes, including computational modeling time. In dominant frequency, in virtual DF group case with DF site located in pulmonary vein, we finished the procedure after PBI alone. In DF group, virtual DF group case with extra PV pulmonary vein DF, we conducted additional ablation to DF sites. In empirical ablation group case with extra PV dominant frequency, we did not touch those extra PV dominant frequency sites. This is the outcome of Cubia AF2 trial. Computational modeling guided additional dominant frequency ablation showed significantly superior rhythm outcome than empirical ablation in patients with persistent AF. Okay, now I would like to present data of virtual enterosmic drug tests. The efficacy of enterosmic drug can vary in patients with atrial fibrillation, and PDX2 gene affects the responsiveness of enterosmic drug. And we explore the virtual enterosmic drug responses between wild type and PDX2 deficient AF conditions by realistic in silico AF modeling. This is a study protocol. We generated realistic AF modeling with the same method of QBAF2 in 25 patients. During induction of atrial fibrillation by ramp pacing, we get the restitution curve and generated a maximum slope of restitution, Smax map. After induction of virtual AF, we analyze dominant frequency, phase singularity, or the AF cycle length after 5 seconds of blanking period. Then we apply the virtual enterosmic drug ion current characteristics to ongoing virtual atrial fibrillation. We applied 5 different virtual enterosmic drugs with high and low doses, depending on the ion current changes referenced in the previous studies. And although we reflected human cell data, some virtual enterosmic drug effects were adopted by animal atrial cell studies. And this is the patient characteristics. We included 25 patient data, and 32% were in proximal AFib status, and 23 of them were enterosmic drug resistant atrial fibrillation, and 2 of them we did not use enterosmic drug clinically because the underlying sinus node dysfunction. And GWAS study was done in 24 patients. This is a result. We applied ion current condition of a PDX2 deficient condition, and compared to wild type, action potential duration was shorter, and Xmax curve was flatter, and AF cycle length was longer, and phase singularity number were lower at PDX2 deficient condition. These electrophysiological changes were dose-dependent manner in all 5 different enterosmic drugs: amiodarone, sotalol, dronedarone, flecainide, and profafenone. The genotypic difference of enterosmic drug-induced wave dynamic change were most significant with class 1C enterosmic drug, sodium channel blocker, compared with class 3 enterosmic drug. It might be because sodium current difference was more significant in PDX2 deficient condition. And the class 1C enterosmic drug induced AF termination rate was significantly higher in PDX2 deficiency condition compared with in wild type condition. This is a summary of this study. The PDX2 deficient model exhibited a shorter APD, lower Smax, mean DF, phase singlet number, and longer AF cycle length. And 5 enterosmic drug changed the electrophysiology in dose-dependent manner, and AAD induced the AF cycle length lengthening and the reduction of conduction velocity, peak dominant frequency, and phase singlet number were more significant in PDX2 deficient condition than in wild type. PDX2 deficient AF was easier to terminate with class 1C enterosmic drug than wild type AF condition. And class 1C AAD exhibited more potent anti-AF effect on the PDX2 deficient condition than wild type. And the virtual enterosmic drug test was feasible for evaluating the efficacy of multiple enterosmic drug in patients with AF. Finally, I would like to briefly mention about the relationship between restitution Smax and dominant frequency. As a sub-study of a virtual enterosmic drug test, we evaluated spatial difference of the dominant frequency and the enterosmic drug by analyzing 2,500 AF episodes. And the spatial heterogeneity of a dominant frequency was higher in pulmonary vein than in extrapulmonary vein under AAD. And post-enterosmic drug DF was higher at low Xmax condition and no defragmented condition. These findings suggest dominant frequency at low Smax condition is easier to maintain atrial fibrillation. As the next step, we further analyzed the spatial temporal change of dominant frequency depending on Smax condition. In this study, with 750 virtual AF episodes, we found inverse relationship between Smax and dominant frequency regardless of temporal changes. And the Smax reflects passive wave break condition. Dominant frequency reflects active AF driver. Therefore, high DF at the less wave break condition might be the real AF drivers. And we verified this hypothesis in QBR AF2 clinical data of 170 patients, and we observed the consistent inverse relationship between Smax and dominant frequency. And Kaplan-Meier curves analysis shows a significantly better rhythm outcome of a DF ablation at low Smax condition than empirical ablation, but not in high Smax condition. So in conclusion, ladies and gentlemen, AF computational modeling has become a stage that can be applied clinically with fast and efficient computation. And invasive map integrated personalized AF modeling improved the outcome of AF catheter ablation in patients with persistent AF. Virtual AAD test is feasible for evaluating the efficacy of multiple AADs in patients with AF. And class 1C AADs exhibited more potent anti-AF effects under PDX2 deficient condition than in wild type condition. And there is an inverse relationship between dominant frequency and Smax, and the dominant frequency at low Smax seems to be a real AF driver. Thank you very much for your attention.